Yeah, we have a quorum, right, Kelly?
Correct.
Pretty sure we do. Okay, thank you. Are any amendments to the agenda required? Seeing none, would someone care to move the approval of the agenda? Thank you, Ken and Kevin.
Sorry,
Dr. Era?
Mr. Chair, for the agenda, if we can add an item related to the update about the contracts that the health units has with certain services,
Okay,
so it will be in camera third party.
okay,
Keely can provide the wording we drafted it before. And days ago.
right, okay. So it'll be in addition to the in-camera,
Correct.
agenda. Okay, and I guess, while you mentioned that, I have an addition as well to the closed session. It's just a verbal update, about the personal matters about an identifiable individual. Be real brief. Okay, with those additions, everybody's okay? All those in favor?
Still good.
That is carried. Thank you very much. Is there any disclosure of pecuniary interest related to any item on the agenda? Seeing none, one should arrive. Kaylee?
Roll call.
Oh. That's a good one. Oh, yes, there it is there. Straight to the start. Kaylee, would you mind taking the roll call, please?
Works. Brian Mill,
Sort of here, I guess. Yeah, a little rattled, but I'm here. Present.
Alan Barfoot,
Present.
Helen Claire Tingley,
I'm here. I can't see anybody. Can you hear
You're
me?
muted, Helen Claire.
Oh, boy.
Oh, yeah, I can clearly.
we can hear you, Helen Claire, thank you.
Excellent, thank you.
Thank
Sue
you.
Patterson,
Present.
Luke Charbonneau.
Here.
Chris Peabody,
Present.
Sue Carlton,
Present.
Kenneth Craig,
Present.
Kevin Eccles,
Counted for?
Nick Saunders. Nick Saunders. Seven.
Okay, thank you very much. Kaylee? Notes, closure, just educational notes. This is something that we started a while ago when Sue Patterson was the chair. We're carrying on now, so I'm going to turn it over to Dr. Air to take us through that.
Thank you, Mr. Chair. The educational notes related to the roles of boards, and this is an abstract from an article published. And year was it published? It's not mentioned here, but in the past 5-6 years, I believe. Regardless, it's related to the hospital sector, so it's not exactly public health, but it really outlines the main roles for the boards of health, and it is in bylaw and policy making. It's specifically the policies level, board level, not the operational policies or the corporate policies. And those are usually established early on in the organization's life. In our case, they're set out, are directed by the Health Promotion Protection Act, well established for the past years, and are reviewed regularly every 2 years. And that's one of the solid foundations of the organization and public health in Ontario in general. All these things are usually set out and reviewed many times. Decision making, that's related to the vision, mission, and strategy level decision making. Again, I think of analogies, and I think of a general or the leader of an army saying, we want that country. This is the direction we're going to. And how is this done? What units in the army are going to be moving? Is it the Navy? Is it the land forces? Are they going to cross that bridge or that highway? All these decisions are usually not related to the strategy, or rather the operation. And the last one is the oversight and keeping. There's a saying in the board management is to keep. The board will keep its eyes on the programs and its fingers out of it. And that's usually works really well. And there was a really good example here where they're setting the tone about equality or quality. So if the area is quality, if the board is going to be focusing in the next 5 years about the quality of delivery of certain programs, they need to set the tone. and that's usually a strategic direction and update, let's say quarterly or annually, will come on the subject. So straightforward, there was a lot of information in the article itself if people are interested in clicking on that link at the very bottom, but in general, this sets out a really good framework.
Thank you, sir. Any questions? Okay, not seeing any questions. We'll move on. The minutes of September 13th are there. Someone care to move acceptance of those minutes? Sue and Sue. Any discussion? All those in favor? That is carried. Thank you very much. Correspondence? There's a correspondence there from Algoma Public Health. Do we do these individually? Or you go through them? Okay, Dr. Eric, please.
Thank you so much, Mr. Chair. So we have four items on the correspondence list. The first one is letter from Algoma to the Premier of Ontario, and it lends itself to urging the provincial government to collaborate across sectors to implement income-based policies to reduce food insecurity. Food insecurity is an item that public health looks after and very concerned and interested in. And there are recommendations to increase minimum wage, raising social assistance and others. And the recommendation there is to receive, the board has supported this item multiple times in the past. Letters, a letter from Simcoe Muskoka to the Minister of Health, the Deputy Premier of Ontario. And the letter echoes and supports the previous letter that came to the board and came from, as a correspondence, came from the Sudbury District Health Unit, and it's related to Bill 103, Smoke-Free Ontario. So the recommendation is to receive, since we already had looked at it. The third item is letter from the Board of Health for Windsor, and it's directed to the federal level, and it's related to the Canadian Coalition for Health School Food recommendations. And there are multiple recommendations there for funding and the support of different school nutrition meal programs and national. And the recommendation also to receive, the final one is a letter from the Board of Health for Sudbury and District, and that's related to air quality monitoring. There are stations to monitor the air quality across Ontario, and it seems there's a request there for more of these stations in the north. And there are requests across the province actually for more stations of the same, but specifically the correspondence is for the north, and the recommendation is to receive. Open to questions, Mr. Chair, as always.
Thank you, sir. Are there any questions related to any of those? Motion to receive? Oh, Kevin, you have a question?
Just on number 3, it's towards that, nutrition, and number 1 has the first one coming from Algoma.
Welcome. No.
Number 1 is, Algoma looking for it, and I guess, is putting food in schools, is that the nutritious program? I just don't get how that is a solution to the problem. We're looking at nutrition as an overall thing and everything, but we're going to, pushing to have more nutrition in school. So, I don't know, some days schools are open 4 days a week. Some days they even manage to get open 5 days a week. But we're worried about nutrition for that part of, for society and whatnot, and the kids. And yet this is driving billions of dollars into the education program, where quite frankly, the education program and our educators are having tremendous difficulty educating our children, not only trying to feed them. I don't think that's the right place for us to be going,
So,
to be going after philosophically. But
okay, that's.
We've already just
philosophical.
received.
That's good. The motion is to receive. Do you want to do something
yeah, we're
different?
receiving. No, we're receiving.
All right, okay then.
Thank you.
Any further questions?
My check.
That's good. You be quiet for the rest of the meeting now. Okay. All those in favor of receiving? That is carried. Thank you. Moving on to media releases. Is Denis? Yep, there he is. Morning, Denis. Welcome.
Good morning. Thank you, Mr. Chair, and through you, there are 6 media releases on today's agenda. On September 25th, Public Health issued a media release on a locally driven collaborative project led by Grey Bruce Public Health. This LDCP project aims to identify and enhance evidence-based strategies for preventing substance use and related harms among Ontario youth. And on September 29th, a media release was issued regarding Public Health's participation in National Day for Truth and Reconciliation events in Grey Bruce, as well as our ongoing work towards reconciliation and collaboration with local Indigenous communities and residents. 2 media releases were issued on October 3rd, one alerting residents that a mosquito pool in Grey Bruce had tested positive for West Nile virus and reminding residents to take steps to protect themselves from mosquito bites, and another on a new locally developed service that will ensure all Grey Bruce residents have equitable access to Public Health Ontario's well water testing program. On October 4th, Public Health issued a media release following a series of drug overdoses in Grey Bruce, as well as a second release after receiving lab confirmation of the first local flu case of the 2023-24 respiratory illness season. And that concludes the media releases on today's agenda.
Thank you, Denis. Any questions related to those? Luke?
Yeah, thanks, Chair. Just a comment really about item number 4, the new well testing things I just said. It's just a final opportunity now just to say thanks to Dr. Aaron and to everybody here at Public Health for that program. And not only does it replace the previous system that was dropped by Public Health Ontario, it expands it, which I think is incredible. You know, the addition of locations in Chatsworth, the town of Blue Mountain, Southgate, and Chesley, in addition, of course, to the one I'm most intimately concerned about, the restoration of the site in Saugeen Shores. It's really a critical thing to make sure that well water testing is available close to where people live, so that they actually do it, so that they have good drinking water and don't get sick. And it was unfortunate that in the wake of the pandemic, Public Health Ontario didn't see the imperative of doing that, but it's also, I think, really worth celebrating that Grey Bruce Public Health did see that need and took proactive steps to get that done. And I might just, if I could, Chair, ask just one question of Dr. Aaron, because it's a question I've received and wasn't entirely clear on the answer. I think I know the answer, but not very clear. Is there any additional cost or expense to Grey Bruce Public Health as a result of this? Has there been some downloading of cost that has come about as a result of us picking up this service?
So, Mr. Chair, through you, excellent question. The plan is to submit one-time funding to the ministry to be covered by the ministry. When we took the responsibility of ownership of this problem, although it's not under our mandate, the ministry was in the meeting, and there is a certain acknowledgement that we have their blessing for them, and the mechanism is to submit one-time funding, and we will renew it as the years go forward and the evaluation of the program solidifies. And historically, when a program is implemented in this way, it will become permanently funded by the ministry by one way or the other.
That's good news. I hope that remains the case. And we should certainly keep it in top of mind how this transpires, so that we can always make the case, if we have to, that the province should fund this program and should keep that funding up. But hopefully it isn't just one-time funding, permanent funding. Anyway, that's it. Thanks again for your work on it. Very, very much appreciate the program. Thank you.
Thank you. Any other questions? Ken?
Just to tag on to Councilor Charbonneau's comments. is it appropriate or beneficial for this board to send a letter to the ministry thanking them for the funding? Seriously, you hate to suck up to them, but it does more than thank them. It acknowledges that they have done it. Here's our small paper trail of you funding it. We acknowledging it. Is it the right thing to do, or is it of no consequence? I'm not trying to make work. I'm trying to add some push to it for perhaps the next time.
And Dr. Eric, any thoughts?
Thank you, Mr. Chair. So I do believe the first step is to evaluate the program as we go and see how big it's going to get or how small it's going to get. And that would decide on the amount of funding as we proceed with that route of one-time funding. It could be very appropriate to acknowledge it and solidify it, like you said, or in different other channels, depending on where the program goes. If we see an uptake, for example, increase multiple fold in the access to the testing and the numbers show that, we can showcase it provincially in one of the meetings. And that would be another way to actually, one, share the knowledge, to get the appropriate credit for the team that is doing it, including the municipality funding or supporting with the locations across Grey Bruce. And the final point is to solidify that bridge with the ministry about funding pilots and expanding what we can do.
Okay. All right. We need a motion to receive these, Kaylee? Yep. Al and Luke, any further discussion? All those in favor? That is carried. Thank you, Denise. Staff presentation. Healthy baby, healthy children, positive and adverse childhood experiences. There we go.
Tara will be joining.
Tara's doing that. Excellent.
Hi.
Oh yeah, there she is. Yeah. Welcome, Tara. Good morning.
I might be presenting as well. Hi. Thanks very much, Mr. Chair, for allowing me some time today. I'm really excited to be here. I watch you guys every month, so it's nice to be involved. My name's, are you guys all able, everyone's able to see my presentation?
Yeah.
Wonderful. Thanks for the nods. My name is Tara Luscombe. I am a public health manager. I manage Healthy Babies, Healthy Children, and the Healthy Growth and Development team, and I'm the Chief Nursing Officer as well. I have worked at public health in some capacity since 2001, so a long time. And I have spent the majority of that time working within the Healthy Babies, Healthy Children program as a nurse. So I'm very thrilled to tell you a little bit about what we're doing right now and how we're doing our work. So thanks for the opportunity. So today I just wanted to touch on something that we've been talking about in our program called ACEs, Adverse Childhood Experiences. And there's also PACEs. So adverse is the negative, PACEs is positive childhood experiences. So I'm going to tell you a little bit about that. I'm going to talk to you about the Healthy Babies, Healthy Children program and how we address ACEs in our program, which is how we support our parents and our patients, and then look at referrals as well. So in the one of the things I think that's important to frame all of the work that we do at public health is really looking at how we are preventing disease. So just a couple stats here on the slide for you. Over 7 in 10 deaths are due to chronic diseases on average. We have our 4 major chronic diseases: cancer, cardiovascular disease, our chronic lower respiratory diseases, and diabetes. And then we know, this is a 2016 stat, but we know the cost of hospitalizations is very high for those diseases. One thing we talk about when my focus is primarily early childhood development, is looking at preventing that burden of disease and reframing how we might be able to target some of that. So we have traditionally had really great public health-based programs that look at the things that we know prevent these diseases, like getting more exercise and having a healthy diet. And those things are all really important. But from an early childhood perspective, in the way that we do our work there, if we can take that back and reframe getting at these chronic diseases from a even further back preventative lens, we might be able to target them starting at an even earlier age and level. So we want to look at these diseases from a person's ACEs perspective, and the experiences that they've had that are negative in their childhood times, and see what we can do about changing that. So I'll tell you about ACEs, and then what I just said might come into a little bit more clarity. So ACEs are adverse childhood experiences. These are things that can include physical, emotional abuse, neglect, caregiver mental illness, household violence. So things that families grow up in. And we know from evidence that the more ACEs a childhood experiences, the more likely they are to suffer from things like those chronic diseases on the last slide, heart disease, diabetes, but also have poor academic achievement and lead them towards more likelihood of substance abuse later in life. So when we talk about ACEs, we talk about what they are with families, and that's really that toxic stress. So toxic stress explains how those adverse childhood experiences that families are involved with, or that people experience, how that then it turns into something that changes who they are and their body, so that they are more likely to experience those chronic diseases. So experiencing our ACEs, as well as things like racism, community violence, without supportive adults, causes what we call toxic stress in families and in children. So activation of that stress response system leads to long-lasting wear and tear on the body, and the effect would be similar to revving that car engine for weeks or months at a time. So when toxic stress, we define as something that doesn't let up. So it doesn't let up, the family or the child has no supportive relationships to help them cope. It's something that makes it hard for them to get through the day, and it can make it very difficult for the adults to have a positive parenting relationship with their children, or allow them to live a life where their children can thrive. So living with that toxic stress can really negatively affect someone's health, and it also affects the children's development. There are things we can do that can help reduce our the effects of ACEs and toxic stress. So for those who've experienced our ACEs, there's lots of responses that can help. So we have our mental health services in Healthy Babies. We provide some supportive counseling around the person's life. We know that things like meditation, physical exercise, spending time in nature can all help reduce the toxic stress. However, if we look at preventing it, we really know that we can help prevent it by helping families meet their basic needs. So connecting them with the services in the community, making sure that families aren't falling through the cracks. We also know, we focus on that in Healthy Babies a lot. We also know that building strong, positive relationships between children and the adults in their life, helping the adults build core life skills, can really help buffer the kids in the family from toxic stress. So Healthy Babies is our program that helps parents build those protective factors into their lifestyle and helps them support their children as they grow. So I talked to you a little bit more about ACEs. If we look at this tree here, some examples on the top, we can have ACEs that come from within the family and ACEs that come from the community environment. So the top of the tree there lists some adverse childhood experiences. So maternal depression, emotional sexual abuse, substance use in a family, domestic violence, homelessness, incarceration, mental illness, divorce, physical and emotional neglect. Those are the things that we target in the Healthy Babies program. These are the families that we're working with who are experiencing this. That's our everyday, all day role, is to work with families in these situations and help them reframe, help them get out of the cycle that they're in. There's also the adverse community environment, so poverty that affects all these things, discrimination, community disruption, lack of opportunity, poor housing, and then violence in a community. So those things are all there as well that are impacting the family. I'm going to show you our ACEs screen. So there's ACEs on the left, and that's what we use when we talk about this with adults. And then there's PEARLS, and that's for children 12 and under. And we will be having a conversation with the adults that they're working with to get a sense of what they've experienced. So when I said people with 4 or more ACEs in their life, this column on the left-hand side are more likely to experience chronic disease issues. So verbal abuse, physical abuse, sexual abuse, emotional neglect, physical neglect, divorce, separation, physical abuse of a parent, alcohol or drug abuse by a parent, mental illness of a parent, and incarceration of a parent. So we look for those, and then 4 or more gives you a higher risk. There are things that can mitigate those. So we can't all control, and every time everyone looks at these screens, you can't help but think of your own childhood experiences and where you are now. There are things that we can or that mitigate how those ACEs affect us. And we call those resiliencies, things that give you resilience. And I can tell you how we build that in the Healthy Babies program with the families that we see. So just that repeated stress response changes the structure and functioning of our brains, our hormone system, our immune system, and our DNA. We work with families that are pregnant as well, and it can have a profound effect on the overall health of the baby. The higher the ACE score, 4 and above, the poorer the health outcome, so things like obesity, heart disease, mental health issues, and addictions. So we really have reframed how we look at things. We no longer look from the lens of what's wrong with them, but what happened to them, and then where do we go together from here? So if we reframe that, we are able to move forward with the family. I mentioned the antidote to ACEs and the things that we do. One of the biggest things we know is connection. So relationships matter. Having a positive relationship, having a place to go for support. In our Healthy Babies program, we build that in. We do that with our families. We know and we teach them how to do that amongst themselves, or how to find those relationships. So having safe and healthy relationships acts as a buffer to protect against the impact of ACEs and toxic stress. We work to strengthen our families. We build those responsive relationships. We build skills of parents, and we work closely with all our community partners, our county partners, our municipal partners, and we help the families get connected as they need to the appropriate sources. So I'm just going to tell you a little bit about Healthy Babies, Healthy Children. So it's a program that's been funded by the MCCSS, run through public health units since 1998. We are a voluntary program, and we're designed to identify and mitigate the risk of poor outcomes for children children who have less than optimal development. We are a point of entry. We have people come into our program prenatally, and we're working on a program where we can get them in as soon as possible. So really early, working with our family physicians, our local delivering hospitals, our midwives, to identify families and have them come and be part of the program as early as they can in the pregnancy. We also have a system where we get our referrals postpartum. And then we have an early ID system. So I'll talk about those as well. It's a blended home visiting program where we have a public health nurse teamed with our parent support workers. So our parent support workers are parents trained by the health unit, and they go in and support the family and bring in interventions based on all the assessments and screens that the nurses have done. So the PHN does the assessments, we do goal setting with the family, we have our interventions, and we link with community programs, service coordination, and our PSWs support those goals in home. They take direction from the PHNs and they offer that hand-on support, role modeling. And we do all this with a trauma-informed lens. So we really understand where these families are coming from. Prenatally, it's very important to get connected with our program if those risk factors are there. We know that what we do prenatally is connect people with the resources that they need from the community. We provide prenatal education. We look at housing, mental health. We can help families and women reframe their lives to, I am living like this now. This is all I've ever known, to what do I want for my children, for my family, for my life moving forward. That's really our goal. We have a lot of evidence-based tools where we sit down and we look at those things with families and we help them build the vision of what they would like for their life and for their family and for their children that are coming. So we see people prenatally. Postpartum, we get our referrals from the 3 local delivering hospitals. It's an automatic setup. So when a family comes home from the hospital, we are notified and we call them within 48 hours of discharge. We do postpartum support. We help them with understanding, the immediate of their own health and of their baby's health in those kind of vital couple weeks of change. And then we are looking at those families that we're connecting with, and we're seeing who, through a series of screens, who might need us further, who might need us for a longer period of time, who might need our help building their capacity so that they are parenting to their best ability. So when we have a caregiver that's overwhelmed, alone, and exhausted, they can have a very difficult time being present and being responsive to their infant. We know that in that first 3 years of life, there are 1 million brain connections being made and strengthened through experiences, either good or bad experiences. So we work with those families to, number one, assess that. We have a few to really targeted multi-question tools where the nurse can assess how that interaction is with the family. And then we work with the family to change through targeted interventions where they need to go. There's a video that I've posted at the end of this presentation if anyone's interested. It's a still-faced experiment. So it's a physician doing an experiment in a clinical setting where he has a video of a mom and baby, and they come in and they're very interactive and they're talking to each other and they're connecting. And then he says, stop. And the mom is required to sit facing her child with just a dead face, a still face. And the child reaches out. They're trying to get mom's attention. They're pointing to things. You can see the child start to dysregulate. You can see the child is getting unsure of why the mom is just sitting there with that stone face and not reacting like they normally would, or not reacting at all. And you can see that child get more and more escalated. You can see that fight or flight, the fears coming into their system. And then mom's allowed to break that. And you see mom's automatic relief, because this is a mom who knows how to connect with their child. But you can see that baby just flooded with, oh, good, here we are. When we are in families that have drug addictions, when we're working with families that have mental health issues, or families that are going through life crises like housing issues, food issues, they can present like that stone face. They really can miss those connections, the opportunity to build that from the family. And then the child can sit there for a very long time, sometimes without intervention, forever, not knowing that co-regulation that they can get from another person. And that can affect them throughout their life. So we really focus on looking for that positive, building our families up, but then also pointing it out and intervening so that that child gets to have a relationship that's supportive, that can be a buffer against the other things that are happening in their life. So we also get families come to us with an our early ID stream, and that's just where someone in the community, our children's aid, our physicians, our Ontario Works workers will connect with us and say, this family needs your program. They need that support, and they can come in. So early ID is just anyone that comes into our program 6 weeks postpartum, so after the baby is 6 weeks, and we can help them with everything that they may need. Our program goes up to 6 years of age or school entry. So as long as a family has a child in not yet in school, we can support the whole family. We have a new referral form that we've been using that actually, it might be tiny on your screen, but if you look, there are those boxes. Those boxes actually are the ACEs. So our community partners, our physicians that we work with can tick those so we know what we're dealing with. And we've provided this form out along with example and an understanding of ACEs for our community providers. I'm also bringing this information to our children's planning tables. We have an early learning table that's in partnership with education and Bruce and Grey counties and their early learning programs, as well as we have a Children's Alliance, which is all of our service agencies that work with children in Grey Bruce. So we've been talking about ACEs, and we've been looking at how to build a better community response. So this is on everyone's radar. In Healthy Babies, we have, I think I've talked about most of these. These are really just our targeted interventions that we have where we look and support families, and it's all evidence-based, and we know it helps build that one-on-one connection between a child and their caregiver so that we can mitigate some of that from an early age. So on the last slide there's that still face experiment. There's a link there that it's really interesting to take a look at. And then just some further videos in case I've piqued anyone's interest and you want to learn a little bit more. One thing we did do, and Denis helped with that, is we have our internal staff newsletter, and there's a really great ACEs and resiliency education session that we've offered out for all of our staff to take a look at and do. So we're kind of building our overall capacity here at the health unit as well around this. Is there any questions that I could chat with you about? Hey.
No, thank you very much for your presentation. Are there any questions? Kevin.
Just an interesting point when you made that about things that can happen with stress and toxic stress, that, you know, the changes. But you made mention that the DNA can change. Like I was always under the assumption that, you know, what you were born with, that's what you got when it comes to DNA.
Yeah.
But
yeah, there's
just shocking.
So through you,
Doctor wishes to respond. Go ahead, sir.
Through you, Mr. Chair. Thank you. It's an excellent question. And there is overwhelming evidence that actually there are alterations to the DNA that would continue with the offspring based on stresses during life. And it was in the First or Second World War where a cohort of people who were exposed to that starvation or hunger during that time, and you would see the changes that happened continue in the offspring. There is no question about that. There is a field of public health subspecialty called epigenetics. So the epidemiology of genetics and how these things change. And that's where, back to your first question from the correspondence, where to invest. If we have limited resources to invest into building the family and the traditional natural progression of life versus the system into school, I would choose the first one any day of the week. If there are two, yes, enough resources to support both, why not? But definitely the Healthy Baby, Healthy Children, without a doubt, has the most return on investment that we can ever do in public health, because you're protecting the individual and their projected health throughout their life and their family and their offspring. Absolutely. And I'll be more than happy to bring more material about the epigenetic in future meetings.
Okay. Dr. Zayed wanted to add something there, please.
Yeah, I just want to add, because I studied genetics and the genetic epidemiology as well. So epigenetics means above genetics. So what does it mean? It means that if we have the DNA, there is something called methylation of the DNA. So this is how the gene express itself. So different expression of genes depend on the factors, environmental factors that we are exposed to. So, for example, people who have genes for obesity, they can have variable expression of these genes based on the environmental factor. People who have genes for diabetes, they have also different exposure. So if they have been in a healthy environment, they might not get expression of the gene or methylation of genes. So the expression of genes is a chemical process which is called methylation, in which the gene expresses itself and appears as a phenotype or from the genotype to phenotype. So some of these factors, like toxic stress, can affect the methylation of DNA.
Wow. Mr. Chair, if
Go ahead.
I know it's out of curiosity of some board member here and out of my interest in the subject, I'll add an example of what Dr. Zayed mentioned, and it's an analogy. I know Dr. Zayed doesn't like analogies all the time, but there was a hypothesis about schizophrenia. And following cohort of people who suffered of it and going back in time when they were babies and when their moms were pregnant. And they found that there is increase multiple fold if the mother was pregnant during the winter and if she had the flu. And so there was that hypothesis, is the flu altering something causing schizophrenia? We know that schizophrenia is across the globe, regardless of the society or where a person grows up, it's almost the same percentage. But when you zoom in on these things, so they looked at the genetics of it, and the analogy that was used is similar to a light that can be turned on by 2 switches. So they should have that predisposition in their genetic to have it, and if they don't get the flu, that's not going to be switched. So you switch one, you have to switch the second one for the light to go on. And if it happened that they were not lucky enough and their mother had flu during their pregnancy, the person can have higher chances of suffering of it down the road. Again, there are many hypotheses to be tested, and my knowledge about this has been old, like this is 15 years ago. And there are way more advanced in it. But it can affect life in many ways or health in many ways, whether it's stress socially or disease that the person can be exposed to or many other factors.
Wow.
I hope
Kevin?
addition was useful.
Yeah.
Do you have anything to add to that, Kevin?
My time dealing with genetics goes back 25 years and the recall just isn't quite there. So, and yeah, I'll maybe bring something at the next meeting on that. The other factor, the other one that you mentioned, Tara, was that face-to-face interaction. And I saw something a few months ago that just struck me as something being how we've changed in raising our children. And the one point was baby strollers. Baby strollers, trams used to be, baby was in the stroller and was looking at whoever was pushing the stroller. Today, we've turned it that the baby strollers, the child is looking out at not the person that's pushing the stroller. And there's been studies done on it that is terribly affecting to a baby that, I guess I'm not seeing who is driving the stroller. The kind of thing was, the baby's a little bit fearful. Who's behind me? Never. And it's that face-to-face contact that you were talking about.
I'm gonna add in too, the opportunity for what we call serve and return, where the baby points at something or looks at something and the parent picks up on that, looks at it
Yeah.
and comments, and then the baby does something back and they do that, not just baby, child. And how that back and forth lights up those connections and changes how that baby's perceiving things. So you're right, they're facing forward and they're out there, and there's no opportunity to pick that up. But then you add on the screen that we also see too, that's happening with the person that's pushing or the child in the screen, and it's a whole other layer of things too. So yeah, it's that serve and return, that back and forth that can get missed in lots of opportunities. We always talk about taking your baby out of a container and letting them be on the floor and exploring that way. But being interactive too, it can make an incredible difference. And it's alarming how many families we go to where that has never ever been on their radar at all. It wouldn't even cross their mind to think of that. And it's such an easy, free, quick intervention that can really change how they feel about themselves, their day, their lives, both parties, right? So it's that's a great example of the stroller. Yeah.
Ken, and then I'll go to Sue.
Through you, Chair. I acknowledge Dr. Era's comments regarding the success and thank you for the presentation, Tara. But I'm wondering, does public health have some sort of means of measuring success on this? Is there an indication that this program is one where there is exponential returns on investment? Is this one where the board should say, well, you know, if this is, and just for the example, if we can't get people to stop smoking in spite of pouring large amounts of money in, but we can see extraordinary advances that, like, it's not the right thing to do. Do we take money out of aid to put it in healthy babies so that there are better results? Is there a means to measure success? Is this an area where we should, and no amount of money in the world can ever resolve the whole issue. I understand that. But is it wise for us to reallocate money to address this really significant, obviously important area of public health? But may I throw that question at you?
Thank you, Mr. Chair. Thank you for the question. And there are multiple ways to look at this. If you look at the system level provincially, and the chronic diseases that were counted, whether it's heart disease or lung disease, those are affected by multiple interventions, whether it's in Healthy Baby or another program. So is there a way to untangle where the benefit came? In most cases, no. However, there are ways to look at the general trend for many years on the provincial level to look at exactly what you suggested. You know, are these programs working more or not, especially if you have programs applied in different areas and not applied in others. So you would have ground to compare. And there are ways. We do it very well in certain areas. We don't do it very well in other areas. For example, I'll give you in Europe, from my work with the World Health Organizations, the road safety is very advanced in public health in the European context, where they'll compare countries like the UK or Sweden, where the number of deaths related to motor vehicle accidents are way less than other countries, and they would look at what interventions they have deployed that were not deployed in other countries. So it's very easy to pinpoint it on the macro level, on a bigger level, on multi-year. But if you go to local programs, it could be done in a different way, where we, instead of looking at the outcome indicators, what's the reduction in death or disease or the increasing quality of life, we look at indicators related to process. So how many visits happened in this area? That's more what we follow up here. And in the long term, locally, we can do some of these, but again, it's very difficult to differentiate where the benefit's coming from. Is it coming from our intervention in the school system or at the family level, so long, because it's the same group of cohort of individuals, but we're following up with. I don't know if that answer.
So the short answer is yes, maybe, but not really.
Yeah, yes, indicators you can. I don't know if the provincial level would allocate money, because sometimes we don't have the, the leverage to actually channel money from one program to the other. We had that before 6 years from now and historically, and then the last 6 years, I believe since 2018 or so, they said, no, you can't use the budget flexibly. Each program has its own budget.
Sue Patterson, please.
Thank you, Mr. Chair. Comment and a question. Thanks, Tara, for the presentation. Some good information, and that's such a positive program. And it reminded me, because I recently read an article about connections and how cell phones are causing problems with parents and children, because parents are on the cell phones and the kids are looking at them but getting no connection because it's a continuous cell phone use. My question is, how many families or people would be in a program like on a yearly basis?
So I can answer that. Yearly, we have contact with everyone that comes out of the hospital. That scores, it's just a minimal score. They're screened at the hospital. So we see them for a shorter amount of time, but families that are actually on our caseload, there's 6 PHNs and 4 parent support workers, and we service around 1,600 with that intensive work through the year. Yeah.
Thank you. That's a
Yeah.
lot.
Thank you. Very good. Thank you, Tara. Helen Claire.
Thank you, Mr. Chair. Thank you, through you, Mr. Chair. Thanks to Tara for an outstanding presentation. Couple of comments and a question, if I may. It really, this presentation can help with the understanding of difficult adult behaviors and the stigma associated with that, when we understand that these adverse childhood experiences that children don't choose to participate in, they're imposed upon them, affect them, their innocence in that way. And I'm hoping also that the offshoot that came out, the information about how DNA becomes changed, will also help with anyone listening understanding multi-generational trauma and how DNA changes happen and then continue to happen through the generations, compounding with the layers of adverse childhood experiences on top of changed DNA. So my question is around a lot of the client base, Tara, that Tara spoke about, have stigma-related issues like mental health, incarceration, substance abuse, domestic violence. How is that handled? How, I would love to know, just if you can encapsulate for us, Tara, how you navigate that delicate balance to go in and help without, when this is horrific stuff often that you're dealing with, that your staff are dealing with, how do you manage not being judgy and re-stigmatizing the very people that need the help? Thank you.
Tara.
Yeah, I'm happy to answer that as well. It is interesting when you've done this work for as long as I have, that question doesn't even come into my mind, because there is no judgment. There is only, we have amazing families in Grey Bruce. We have families that, no matter what their circumstance and what they're dealing with, I have never in my 20-something years not met someone who doesn't want to do better. So our families come with often a way clearer understanding of where their faults are than, I mean, it's sad. They know where they're failing. They know where they need help. And then our role as Healthy Babies staff is to meet them where they're at, to set goals, to let them know that they can change what they want. And then work alongside them. And there will be ups and downs. There will be, law involved. There will be relapses. There will be those things. And we have an incredible training program. Our nurses and our parent support workers and even our program assistants that do this work really get what trauma looks like and how to focus our care with that trauma-informed approach. And we do that with some really robust evidence-based tools that we're very familiar with. And we work with our families from that lens. So we aren't re-traumatizing, and we're there to support and reconnect again and again and again if they need it. So that's when you asked that question, I thought, oh, it's not even we don't judge. We just this is what we do and we love it. And these are the families we work with. And there's always a positive. There's always something that comes out of a connection with a family that can lead to lasting change when we're involved. I really believe that. Yeah.
Thank you, Tara. Ken?
Thank you, Mr. Chair. I'd like to inquire about the policy for intervention. I heard Tara say, you identify the families coming out of the hospital. Is that hospitals through obstetrics? Is that hospitals through childcare? Is it just the hospitals in Grey Bruce? Is it just the hospitals that provide obstetrics? What's the, when you say you intervene at the hospital, like what is the policy? What does that mean? Tara?
Oh, yep, I can talk to that. So there's a universal program throughout all of Ontario where every family, if they consent to it, which is the majority, it's usually not something they don't consent to. Healthy Babies, Healthy Children Screen is completed, and that's an evidence-based tool that looks at area of risk. It's completed at the hospital by the hospital staff in Grey Bruce. There's different models throughout Ontario. We have liaisons in Healthy Babies, a couple of our nurses that are paired with our delivering hospitals. Our local hospitals and our service agencies and the social workers involved with those hospitals are all aware of our program. We've been around for a long time and we're connected. So the hospital referrals can look like a social worker, for a family of a 3-year-old that had been in Emerge to that regular flow of referrals from the hospital through even the systems designed that their data inputting, the nurse right there on the floor, it comes right in, connects with our data system, and we can pick up from there. And then we reach out to the family. So that screen is done on a universal basis across Ontario.
Do principals and pastors and mayors have the ability to refer?
Oh,
you, Chair?
Tara? I have no idea.
Yeah, absolutely. We have a referral form on our website for anyone to fill out. You need to have that conversation with the family you're referring. People can self-refer, community members can refer. And yeah, absolutely. We are, and we're also a no wrong stop kind of idea too. So if we get a referral, it's not exactly a right fit for us, but we can, we have that conversation with the family and we move them to the services that they need.
Good. Thank you, Tara. Appreciate, Dr. Aaron.
Yeah, I just want to add to Tara's comments. First, I want to thank her for the very great work that the team does in the field and for the great presentation. I want to add to her last comment. Anytime you want to implement a program like Healthy Baby, Healthy Children, referral would work, and that would be active way to bring people in. The passive way, although passive usually is a negative term, but in this case, it's a stronger way. Everybody who's born, if they're identified by the team that is going to help the delivery to have a certain score, will be referred. So that's where we catch most of the individuals. There is benefit in going proactively and finding people during pregnancy. And that's what Tara has been working with the family health teams or the healthcare providers to provide that early identification, and there could be ways to improve the system no matter what. And if there is a way to identify people when they go into pregnancy, that will be the best way. And if we can implement it passively, and that will be suggestion to the ministry to implement screening system, that would be where the money is actually. But again, it's a process of improving the whole system, not just our company.
Al?
I guess that was gonna be my question, when it was identified, if it's after the birth or during the pregnancy, but I think you've answered that, Doctor, that it's after, but.
Okay. So again, thank you very much, Tara. Good presentation. Lots of questions, good questions. Thank you very much. Okay, moving on. We don't need a motion to receive that, I don't think. No. Good. Medical officer health update, and I'll turn this over to Dr. Eric.
So the first item is with Dr. Zaid, I believe, Mr. Chair, Orchid situation. So
very good.
I will delegate.
Dr. Zaid.
Thank you, Mr. Chair. I will share my presentation for today. Mr. Chair, I know, it's got me. Okay, sorry for the technicals. I'm just today want to talk about the locally driven collaborative project, the LDCP project, for the risk and protective factor and understanding the preventive intervention strategies for youth between 14 and 25 years of age. And that was our project about focusing on prevention that came to completion. So this is an overview, a quick overview of the project. The main point are the background, phase 1, which is a systematic review, and phase 2, talking about the survey that we did to have an input from public health unit, and followed by a qualitative in-depth census of the information that we got from health units. And I will end up by talking about the takeaway message from both the literature and the applied survey. So again, just for a quick overview about the scope of the study, which has been the current practice in public health units across Ontario, and that is compared to a systematic review or comparing what is happening on the ground versus like a perfect or near perfect recipe. The focus concentrate on primordial prevention, and primordial prevention meaning like practices that address social determinants of health and adverse childhood experiences. And primary prevention is meaning addressing risk and protective factors in a community. And that can be in a school setting, in a community setting, or across the socio-ecological model, which is, as I will mention later, about individual, interpersonal, family, and then we go to community and society. And then addressing the impact of the pandemic. So our study started from 2018, just 2 years before the pandemic. And that just at the time where all the systematic review stopped at this time. So we continue systematic review across the North America from 2018 till the end of 2022. And the role of public health unit is important for this study so that we come with some sort of focus on prevention, because we always talk about harm reduction and treatment, but what about prevention? It's an important pillar as well in the combat against opioid and drug use. And then the outcome is to build a knowledge base that can inform the practice in public health and inform what kind of program they need to choose, what kind of indicator they can select to evaluate and measure success. So the systematic review briefly, we have gone through 1904 abstracts. And this is for the risk and protective factor, and then after selection it was 1498, and then the full text review including 39 articles of intervention and 72 study for risk and protective factors. In the end, this is after the AMSTAR review. And then, so we really did not a rapid review, we did an in-depth review. And the full text after grade, which is another tool of evaluation, we ended up with 19 studies of intervention and 26 studies describing risk and protective factors. And when we have this evaluation, we mean that these studies have been proved to be impactful, have been addressing a wide range of population, have been evaluated over a long period of time. So that's the validity of this sort of studies or evaluation that we did. So we have, for the protective and risk factors, we find 17 individual factors, 3 interpersonal or peer influence, and for the microsystem, including school and family, 5 studies, macrosystem is 6 studies. The most important individual factors in terms of risk and protective factors, and this can be helpful for any programs, like for example, Healthy Baby, Healthy Children that we just talked about. So what is important risk factor we should take care of? At the genetic level, this is the genetic predisposition or family history of substance use disorder. In protective factors, the cultural identity and the ethnic identity is a strong protective factor. Mental health internalizing versus externalizing the behavior or risk behavior or mental health illness. So there are mental health conditions such as depression and anxiety, conduct disorders. They are risk factors to lead to opioid or other drug use down the road. Protective factors, including reflective process and optimism. So this is kind of things that we need to have when we focus on individuals at certain age groups. Impulsivity and self-control have been really a very big part or very big individual factor. And teaching self-control and regulation in early years have been very useful. The self-esteem, as low self-esteem and self-worth can be a high-risk factor. The ACEs and history of trauma, and especially the cumulative ACEs over time. So when we highlight or outline some adverse childhood experiences, but if that continues over time, there will be a cumulative effect, which is, again, it's like a logarithmic or arithmetic mean, where things will be accumulated, not even double or triple, but just much more than that. And then the parental separation below 18 years is, we find that this is one of the highlight of risk factors. If we talk about interpersonal, so there is, in general, there is the bullying effect, and the protective factor is the pro-social peer network against bullying. has been really important. And that will is important factors that we need to be careful about, take care about when we are having some school-based program, for example. For the microsystem, the academic performance, so putting a program for academic to continue or retention of students can be really a protective factor here. Positive family relationships, parental involvement, family role, and parental monitoring, intact families with warmth and predicted social ties, family socioeconomic status, residential stability. So some programs really have been built on this sort of program like Planet Use and Icelandic model. They have been built based on this family intervention of protective factor. As a school, also as protective factor, the strong social support network and school and participation in extracurricular activities. So if there is funding for extracurricular activities is really important and it can be really purposed for the prevention of substance use. For macro system, which is the society and community, there are factors related to cultural norms and attitude that tolerate or glamorize drug use, media portrayal of drug use as normative or desirable, neighborhood poverty, crime rates, availability of drugs, limited access to education, recreational opportunity, inadequate drug prevention and treatment resources in the community. The protective factors include community monitoring and community support. For the intervention, so that was about the risk and protective factor. For intervention, as I mentioned, we have 19 studies and 5 of them were addressing social determinants of health and ACEs. 14 studies were focused on youth, with outcome focusing on youth in 3 reviews, children in 4 reviews, and children and youth in 2 reviews, family in 2 reviews, and community in 3 reviews. I just here put some examples of those 19 studies. So there is teacher-provided intervention, and the theme of that program is behavioral intervention, and it's mainly focusing on 5 learning points. It includes parents or participation of parents, but through a school-based intervention, and it is led by teachers and social worker, and it is in school, and it was found by evidence that program of preventive intervention that happened in school are stronger than those that happen in the community, because it focuses on children and has this ability to evaluate the program down the road. So there was some outcome indicators that needs to be that have been measured over short term and long term. And short term meaning for less than 1 year, and long term was from 6 to 9 years. And that includes substance initiation index, sexual protection and risk behavior, family adaptability substance initiation index, rates of antisocial behaviors in youth from families engaged in these programs. So that was follow-up of these families and students engaged in that program. It is important to see also that this program focused on multiple risk behavior. So it is not only about the drug use or but it also address something like sexual healthy behavior, risk behavior, and other risk behavior, driving or taking risk in general. Another program that have shown some promise was promising result in the last couple of years is using computer technology and theory-based targeting primary prevention. Again, this program is school-based, and it improved the resilience. So it measures how the engaged students in this program have higher resilience, in addition to successful outcome for harm reduction. Like it is mainly for primary prevention, but this program also had an expansion scope for secondary prevention or harm reduction. And the prolonged use of this program has a stronger effect and more significant knowledge gain and more likelihood to implement the protective factors. Multimodal family and community, and this program has been applied different program, strengthening the family program, and has been used in the family and community. And this was specifically for volatile substance use. And it has been like this volatile substance use have been used by like blue solvents and all these gases to achieve intoxication. And this has been kind of abolishing or trying to minimize the pain. So this program has been targeted to those who have been using this material and their family members, including the children. Another program, which is also a concept, which is a youth participatory approach, is how to involve youth. We always say we need to involve youth. So this program really explains in details how to take these steps to involve youth in or engage them in social action, and at the level of policy, in addition to peer support. That is really critical for any successful program addressing the youth. Another program, which is the Strengthened Family Program, has been really widely expanded in North America, and it can be in school or community, and encourage interaction between children and parents. And again, there are some indicators for that program with those who have been enrolled about the self-control, resistant to peer group pressure, and the parental skills and family relation. Of course, I cannot really state every program here or all that, but all the intervention. But some of the here also some example of this intervention that is important. Intervention program focused on children with parents with opioid disorder. So that is something that we can work with healthy baby and healthy children, and also healthy growth and development to establish this intervention program that help adolescents to thrive. Optimal opioid stewardship, and this is very important because in hospitals, so we have here hospital committee for prescribing medication. So it is important to see children who have undergone operation surgeries. So we need to make sure that the prescription really does not lead to any sort of drug use down the road. Cultural adaptation, tailoring of the intervention, and this has been very good program, widely accepted across 22 countries. And some of this program also is related to it can adapt it with indigenous population. The second part of the which is what is on the ground and what public health unit is intake for that. So we started with a survey, pilot 5 health units, including grade groups, and then we generalized the qualitative study and the interview over 22 health units, and it has some themes, and the themes including reflexive thematic analysis that was included. This is, in a nutshell, the quantitative result, and this is 22 out of 34, and a health unit. The good thing is that it is geographically representative, and the population representative as well. So we can see here mainly rural, sparsely populated, urban-rural mix, urban centers, and urban-rural mix. So these are the C's that were for the qualitative in-depth interview, include the role of partners of public health and use, program planning and delivery and evaluation, also the contextual factors, risk and protective factors. So these were the themes that were built, we built for the qualitative censuses, and were answered by the public health units. It was very useful, and in the end, we had some good inventory of the primordial and primary strategy in public health unit. Some of the program that we mentioned was prevention program for youth mental health in schools. And this is an evidence-based program started in Montreal and then was adopted by schools in across Canada. Youth wellness hubs in Ontario, Icelandic prevention model Planet Youth, and youth coalition and youth-friendly communities, strengthening families for parents, focus on social determinants of health. So these are the main items that were named by the health unit. And in conclusion, the health unit perspective here is prevention, that prevention of new substance is really a complex and multidimensional challenge, deeply connected to and impacted by individual, interpersonal, community, environment, and risk and protective factors. So when we develop a program or adopt a program, we need to have this kind of context in our perspective. Nearly all public health units underscore the prioritizing the preventive strategies and intervention as essential. In terms of the implementation of this program, the complexity of partnership with different stakeholders for program planning, delivery, and evaluation. So it is really diverse, complex partnerships across the health units that we question. The flexibility needed to have different roles, systemic factors such as public health and funding priorities are the main issues or component that were mentioned by mostly all health units. Different context and relatively recent emphasis on risk and the protective factors. So the key point here, it's important to have these foundational pillars and determinant concepts in developing and evaluating program. Focus on protective factor is really important, and it has to be based on age. Like if there is a program that is above 12, it's really late. So focusing on certain protective factors before 8 years old or from 8 to 12 is also as really important. System level collaboration is really important, as you can see, the socioeconomic and how it's affecting this level. The formalized partnership and youth participation is important. These are evidence-based tools that are from the literature that can provide indicators for any program for evaluation. So any program, we need to evaluate the reach and accessibility. So how many people can access the program, or how the percentage of this program reach youth. Implementation fidelity. So how we need to see, like for example, in Iceland, they have a huge implementation fidelity for the Icelandic model. Their process is very strict and very meticulous. Participant engagement and satisfaction, and the feedback from enrolling people, the health outcomes and equity disparity, stakeholder engagement and collaboration. So these are main items in which we put indicators to evaluate the success. And beyond that, this item of conventional evaluation, there are items that needs to be assessed, the social connectedness, how this program achieve social connectivity, community partnerships, supportive community and school environment for youth leadership, and individual and community resilience. So that's it for the presentation.
Thank you, Dr. Zayed. Without trying to make it simplistic, because as you say, it's very complex, I would suggest an ounce of prevention is worth a pound of cure. Anyway, any questions? Luke?
Yeah, thank you, Mr. Chair, and thanks for the report. It's a very interesting to hear you speak about it, and interesting to read it. That's what the chair said is, I think, interesting because it's true. It's true, obviously, that, you know, trying to prevent these things is what we want to do. The question is, what exactly of these things are we going to focus on trying to prevent, right? Like because when you look at all the fact, like it's everything is a problem, right? Like everything about your individual life, everything about your interpersonal relationships, everything about society. So I don't definitely make the conclusion. So I only just say, what does public health, like, I mean, we only have a certain sphere of influence and a certain level of responsibility. And I think we have it, you know, I'm not smart enough to focus on more than a couple of things at once. So I wonder what is the lowest hanging fruit? What is the thing that we can say? Like, I think we ultimately want to get to a point where we can say as an organization, this is the piece or a couple of pieces that we can have an influence on. It's the lowest cost, highest impact. And let's make that the priority. And once we've solved that, if we ever solve it, maybe we can move on to other things. But so are we, and maybe it's too early to say that and what that is in this process, but are we getting to a point where we can say, Great Bruce Public Health, this is the piece that, you know, maybe it's healthy babies, healthy children. Or, you know, that's a great thing we're already doing. Maybe we ramp that up, or, you know, what is the thing? Is that a conclusion we're going to reach at some point?
So it's already, through you, Mr.
Please.
Chair. So it's already thought about when we were actually preparing or before preparing that. And it is actually it's more difficult than really preparing and developing this report. But the most important thing that we are working on it right now in terms of implementation. The first one, as you mentioned, the low-hanging fruit, for example, opioid stewardship program in hospital. Working with a Healthy Baby, Healthy Children program, and we started that, and the school health. We started to have sort of matrix management structure so that we involve prevention, not only like we have a harm reduction program. So it's not going to be only harm reduction program, it's harm reduction prevention. And in the same time, working with health promotion team, working with Healthy Baby and school. We will have in the near future, working with school boards to adopt what kind of program that could be successful in our context. The other part that is important is working provincially with the OMO group. So we have a systematic approach for things that we can adopt provincially from that study, and that's very important. The other part also, the Office of Chief Medical Officer of Health, they have the report and they are working on adapting messages from the report in while they are changing the Ontario Public Health Standards. So while they are in the process of doing that now, so this report will be a reference, one of the reference to do that. So there is a plan, and local plan, provincial plan, and
And I appreciate it. I just, I guess what I would say, and maybe message more to the board, that you, Dr. Zag, because I think it's important that you're working on the broader issue and in all those areas. But I mean, there you listed 5 or 6 different things going on, right? And you really just can't become that for this board, I think, become that spread thin, right? Like, I think we need to, you know, like the school stuff, right? Like, the schools have their issues, it's a provincial issue, it's a school board issue, we can offer them this report and hope they take action on it, but we should really actually say, you know, that's your piece, and you guys have to address those things, right? And that's as much as we can do. But in terms of our own work, like, I really like us to get to a point where we're saying, you know, one or two things at most, right? Like, let's really go in hard on healthy babies, healthy children, and maybe stewardship of opioids. And let's make that our thing. That's our thing. That's what we're doing. And all this other stuff, you know, we know it's an issue, and if people come to us and say, are these things issues? We'll say, yeah, those are issues. And if you and your schools or province or federal government, if you want to address those things, we're going to be very supportive of that, because you need to address those things. So for us in this organization, these are the pieces we're focused on, really not working too hard on anything else, just because we don't have capacity. So as maybe that's the direction we're heading in, and if that's the case, then I'm certainly strongly supportive of that.
Dr. Aaron? Yeah, I really appreciate the question and the input on that's the strategic direction. Public health issues, unfortunately, are multifaceted, multi-sector involvement. They're entangled in a way that we can't just go and pay the hydro bill, not the phone bill. If not all of them are addressed, we're not meeting our indicators. And this is prescribed by the Health Protection Promotion Act to fulfill these functions. And that's the act. Then under the act, there are regulations, which is the Ontario Public Health Standards. So these standards are being reviewed, or the plan by the ministry is to review them next year, and the outcome of that review might change them or alter them. And one reason for the review is what you mentioned. The second reason is the limited budget that we have. There is increase of 1% in light of inflation. It is a budget freeze or budget reduction, more or less. So the ministry recognizes this, but you know, you put everything on the side. Can we do one or the other? It can't be done. It just can't be done. And this is the nature of public health. From a board point of view, like you said, you know, you need indicators that you would look at and see how things are progressing. And this is part of the orientation would address many of these things actually, where the Board of Health would direct the operation into deal with the opioid crisis. This is number one, for example, in our strategic plan, rightly so, for many reasons. Then how this is dealt with and the multiple interventions are operational. And, you know, maybe you want a summary of all these operations in 2 or 3 easy indicators that would be proxy to the rest of them, which is very appropriate. You know, at the end of the day, the board meets 12 times a year, 2 hours, that's 24 hours. No one of us around the table, including me, can actually go and see what every nursing staff is doing and public health inspector is doing and all these programs. So the higher level in the organization we go, and the board is the highest level, you would look at indicators related to a scorecard, and they're simply 4 quarters in a circle. And again, this is, you know, when you look at the orientation that's provided on annual basis, would very clearly say, as a board member, you wouldn't have to be experienced in any of those frontline things. And that's, you know, if the request is to narrow down the presentation into indicators that are proxy, we can definitely deliver on this. For the past 9 months, there has been more requests about what happens here and what intervention. And I am with you in that it should be narrowed down, but that would be the board direction.
Dr. Zan.
I just want to add a point here. There is a strategy, short term, medium and long term, based on our strategic direction, as I mentioned. So the short term, I agree with you. It would be easy to get this opioid. There is a committee, so we can working on with this opioid stewardship, changing some focus in our healthy baby, healthy children. So that's really started already. The medium term thing is our formalized partnerships. So how we can help schools with this, like how that would be input. The other things provincially, maybe it's a medium term, but it's very good that the ministry or the chief medical officer of health office offer to have this to change the standards. So the standards will affect everyone, and the standards means funding as well. So that there are long-term plans, there are medium and the short-term plans. But yes, I agree with you about the short-term is opioids and ACEs for the healthy baby.
I'll go to Al first and then I'll go to Sue Patterson.
Just to follow up on Luke's point, I think like there are issue this afternoon on the orientation. I mean, it sets a strategic plan and goals and that, and I think the follow up on what Dr. Ayers said. I mean, that's something we look at this afternoon and see what direction to take on itemizing some big issues.
Okay, thanks, Al. Sue Patterson.
Thank you. And thanks, Dr. Zayed, for the presentation. I'm really pleased to see all of this detail. We hear so much about the results of addictions and we're asked, what is being done to manage it? So as you can see, there's a whole lot of studies and work going on behind the scenes. And I know public health has a role during this entire cycle. And we know that prevention will give us positive results. And I did hear at one of our meetings that it's generational, the solution. So can Dr. Zayed or Dr. Era speak to that? How long is it going to take before we start seeing positive solutions on this?
Dr. Zayed.
As I mentioned, through this intervention programs, there is a short-term intervention impact or evaluation that's for 1 year, and then there is medium term from 1 to 3 years, and other programs have been to 9 years. So there is actually indicators and evaluation that has to be on stages. So we can say 9 years or 10 years, you can have much more. You can see some changes, but of course there is some changes after 1 year. I have to be optimistic too. But in the same time, I'm working on other levels of secondary prevention and treatment and other pillars. But prevention really takes time, and it works from early on and below 8 years to an age of youth. So even the impact of youth for 15 and 24, you have to work with the students or the children to reach that age and then see how that will affect. But we have to keep to be positive and optimistic. The most important thing is just to start and work consistently. Like consistency is really important.
Thank you. Dr. Ayers, did you want to add something?
Yeah, thank you, Mr. Chair. So you look at similar problem in a certain way. Smoking, tobacco smoking, it's addiction. It has multifaceted. It's social, individual, and all these things. And you look at the history of it, 30, 40 years for the reduction in the change in the behavior in the society change. And before you change the behavior, you need to change the attitude. So it's related to education and to the next generation. It's related to helping the individuals themselves who are inflicted by that. And if you look at indicators, again, I'm referencing the European indicators that look at how can we reduce by 50%? How many years it's going to take to do this? So if we can reduce by 50% in 10 years, that will be excellent. Last year or 2 years ago, there was a reduction from 21 to 22 in the number of deaths of opioid, and it was around 50% in 1 year. But we all know it was related to the pandemic being there, a lot of stress and a lot of our resources going to something else. There is an abrupt change of 50%. Can we maintain 10% reduction every year? That will be a good indicator if we can catch up with that. But there will be a reduction, and it will be zigzagging up and down on few months level, especially with Grey Bruce having small number relatively. We have 20 deaths. We had 20 deaths last year. So if there is a party where a number of people overdose, that number is going to be skewed. But if you look at it at the provincial level or Grey Bruce over a number of years, we will see the progress. And so long that the progress is in a positive direction, we will be reassured. We will do our best from epidemiology point of view to weed out which interventions, and that goes to Ken's question, have more weight. But we wouldn't know at this point. It's similar to, it's not where the buck is, where it's going to go. And so long as it's heading in the right direction and we have the levers to influence it to a certain degree, that will be the work of the health unit.
Okay, thank you very much. Thank you, Dr. Zayed. Do we need a motion for each individual report or just for the whole section? Okay, good. So Dr. Era, the next is public health modernization. Is there anything to report there?
Minor update, Mr. Chair, the criteria was expected from the ministry early October. We didn't receive them. In other words, they're going to be coming early November, criteria for voluntary amalgamations among health units. And that set of criteria will help us plan locally. Nevertheless, we are working in senior management on finding a number of efficiencies, and a report is coming to the board, and part of it is in camera on certain findings, efficiencies related to expenses, not just related to FTEs. At this point, we're still looking at how we can cut our expenses. There are health units looking at number of health units looking at layoffs, and this should come out in the near future. And again, this always increases the anxiety in the sector. And because of that, and because of transparency and all these things, we have designed bi-weekly communication to all our staff to keep them posted so they can differentiate between rumors and what announcements from the ministry are. And we're working on increasing team binding exercises, whether it's related to holiday decoration or the parade. And Haley has been instrumental actually in arranging a number of these activities. So at this point, that's the update, Mr. Chair. Nothing significant.
Very good. Thank you. Locally driven collaborative project. Say that fast 3 times.
We just did that.
You just did that. Yes, we did. Okay. Staff report on outbreak preparedness and response.
Mr. Chair, this is a report, a report about different programs, and one of them is the outbreak preparedness. This is infectious disease program is one of the strong assets that we have. During the pandemic, it was augmented in capacity and experience, and very experienced team has always been before, but it outlines the number of outbreaks we're dealing with and the capacity we have for it. And, in general, it's good news, strong team, strong response. And if you look at the bottom of this report, I wonder, Kaylee, if you could share the screen of the report. There is one point there that builds on what Luke mentioned, which is very, I agree with him 100% about narrowing the indicators to the strategic plan linkage, and that's what we put in our presentations. Second page, please, and if you can make it a bit bigger. In every report, I realize the board has been requesting details and more details, but we always go back to the strategic level, and you'd find these 5 areas, and this report would meet the last one, and I would say we meet it very robustly. That would be very appropriate for an update with, instead of listing all the details that we listed. So I am with you 100%. It's music to my ear that the board, your request is to focus on certain things. So this report would meet the main indicator to improve and prevent and control communicable infectious disease, and that's robust.
Very good. Thank you. Any questions? I can't, oh, they're there. Focus on the screen. Who's got their hand up? I can't quite read that. Is that Sue? No? Okay. Nope. All right. Okay, so if we had a motion to receive those reports, Luke, seconded by Kevin, all in favor? That is carried. Thank you very much. Corporate services, we have financial report. Kim, good morning. Welcome. Yes, it is still morning. Thank you. Floor is yours.
So through you, Mr. Chair, this is the August 2023 financial update. At the end of August, we had a deficit of 227,000. As of or prior to August, our base funding for our mandatory programs was covering all of the mandatory programs and the COVID program costs that we had year to date. Starting in August, we did have to start reporting some COVID extraordinary funding that we would require to fully cover our operational costs, which is we built that into the budget. We knew that that was going to happen in the latter part of the year. So that's just matching or just aligning with what we had budgeted. So start to see that in August, and we'll probably see that for the remainder of the year. Our seniors dental program had a deficit of 271,000. So it's primarily what's making up the deficit that we're seeing on the statements. In our third quarter financial report that's due next week, we have submitted a request for additional base funding for that program for this year to cover that current deficit, as well as what we project the deficit to be by the end of the year. So we're hoping we'll know by middle of November, early December, what additional funding we'll get for that program for this year. Looking at our year-to-date funding and revenues, as of August 31st, they're under budget. As we only received the 1% from the ministry when we budgeted for a 2.5%. And as well, the ministry one-time funding. That's the COVID funding that we built into the budget, but year to date, we haven't had to report as much revenue as we originally budgeted. So that's why that one is showing under budget. Our salaries and benefits are under budget by a similar amount to last month's report. And again, that's, we budgeted at the outset of the year for all of our permanent staff and contract staff to be with us for the year, but through leaves or other people taking contracts elsewhere, we've had some gapping. So that's resulted in those variances. For operating expenses, they exceed monthly budget by about 67,000, and this continues to be related to the higher expenditures in the dentist and denturist fee line, which all relate to the seniors dental program. And the large purchase service amount relates to the implementation of a new software that our PHIs use for their inspections. We moved to a system that a majority of the other PHUs across Ontario use for our inspection software. Lastly, for our capital updates for the Waterton Dental Clinic. So we issued a construction RFP. It was closed and we only received one bid. The current funding allocation that we have for the project is not sufficient to cover the cost that we're seeing come in. So we're currently working with the Ministry of Health to see what options there are available to cover any projected shortfall. And we're also working with Colliers, the project management firm we hired, to see what options are available to determine next steps on that project for us.
Thank you, Kim. Any questions? No, no questions. Risk management Q3, is that you as well, Kim?
Yes.
Okay, please.
For you, Mr. Chair. So this is our third quarter risk management report. So this report goes to the Ministry of Health annually, and the purpose of it is for boards of health to report to the Ministry of Health in a standardized manner the high risks that they are facing. So each risk identified, we scored the impact of it as well as the likelihood, and based on that, we came up with 3 high risks that we think are currently facing the organization to disclose to the Ministry of Health. The first one are that our base funding increases are not keeping pace with the large inflationary costs that we're experiencing. That impact is high and the likelihood is high because it's happening at the moment. So to mitigate that, we're going to continue to request funding increases and advocate about the funding pressures we're experiencing in public health, effectively negotiate all contract renewals, find organizational efficiencies and reduce costs where we can, and continue to maintain fiscally responsible policies. The other one is the potential for a breach of privacy through a cyber attack. So the impact of that would be significant to our organization. And the likelihood is we've, in consultation with our IT manager, felt 3 was a good assessment of that, just due to the frequency and the advancements that they're making in that area. So we're going to continue to invest in our IT infrastructure. We're focusing on training and educating staff, and also maintaining the education of our IT department to keep ahead of what's going on. And the last one is the change in provincial direction regarding the organization of public health. If there is an amalgamation or merger or health unit, that will have a high impact, and based that it's, and that's currently being discussed, the likelihood is high at the moment. So those were the high risks that we identified to our organization we identified for our organization to disclose to the ministry this year.
Thank you. Any questions? Luke?
I think it's, I just wonder, it's obviously a requirement, it's required that we publicly report these risks to the ministry? Does it have to be a public report?
Well, it has to come to board for approval, like it's a requirement that the board approve it, so I guess unless it falls under one of the requirements for an in-camera item.
Just seems unusual, Mr. Chair, to report particularly technical risks like cyber risks publicly
In open session.
in open session. I think that I think it wouldn't be a standard under the act to be presented and closed, and I think that perhaps in future it's something that the administration should think about, because I don't think it's a good idea to report those things in public.
Dr.
The requirement for, or the prudence to go in camera for matter related to, for example, insurance is definitely there, and we always do it. And if we decide to go for insurance, we would absolutely go to the in camera. This is the risk that faces our organization. All the items there are absolutely public, and this is a practice for a long time, and it's appropriate practice. I stand behind it 100%. And again, if there is, even if we have insurance of certain things or don't, or if there is security to the building that is required a discussion and a decision, that will be in camera, but the level of risk is public.
Jared, if you report IT vulnerability in public, it's not something municipalities do. I can tell you municipalities report these things in closed session. It's security of the property. And I would say that you should not broadcast your IT vulnerabilities publicly. That's it's not common practice in this, in my experience.
So, Mr. Chair, I would defer the rest of this discussion, because like I am concerned, if I explain my point a bit more, I'm going to be revealing certain things that actually would be security risk. But presenting the risk itself is, we have one of the most robust IT operations in the area, no, second to none, I would say, that I'm aware of. But presenting the risk is definitely a public matter.
Yeah, perhaps we could refer this to staff for a more robust conversation in closed session at our next board meeting. Just to allow Dr. Mayer and the management team to explain to the board. You know, I understand Luke's position, but when you explain that we have significant robust deterrence against, you know, those perceived threats, that like whatever we need to hear in close, we should hear in close so that we understand better. So just to refer it for a future meeting, determine when it should be on, next month or 2 months or whatever.
Yeah, good point. Thank you. Any other questions? Hearing none. Not sure it's taking minutes all of a sudden, but I'll take a motion to approve the financial, or maybe we'll just wait a minute until Caleb comes back.
No meeting.
She's not clear.
Well, recording secretary, unless somebody else is going to take a minute, but we'll wait a minute. He's probably gone to check on where lunch is at. Can't wait too much longer before it's coming.
It's a PD day today, so the all sorts of years going to be like
Yeah, that's what all that traffic was.
parents and kids going to hockey schools.
There she is. So motion to receive the corporate services report. Ken, Kevin, any further discussion? All those in favor? That is carried. Thank you very much. So we have an in-camera session. It shouldn't take too terrible long. Want to take a break? Yeah, let's take 5 minutes and we'll come back at noon to do the in-camera session. All right, we'll bring the meeting back to order. we have, I need a motion to go in closed session to deal with the items that are listed there. Ellen Claire and Ken, all in favor? That's carried. Thank you very much. Who wants to adjourn? Ellen Claire does. And Ken, all in favor? We stand adjourned.